and welcome to our presentation on all aspects of breast health, from screening and self-exams to lifestyle factors for optimal breast health. Today's discussion is brought to you by BreastLink, and we'll be hearing from a few dedicated breast care specialists. I'm Stephanie Landon from BreastLink, and I'm thrilled to be your moderator for what is sure to be an exciting and informative discussion. Before we get started, I want to quickly go over how we're going to do the Q&A portion of this discussion. Because we want to make sure we get to all of your questions, we're going to hold questions until the end of the last presentation. However, we are going to try to limit the Q&A to around 20 minutes, so just keep that in mind. And if we don't get to your question, we will provide an email where you can still ask your question and get it answered. If you would like to ask a question, please type it into the chat box and I will read it to the appropriate doctor. If you can, please indicate which doctor your question is for. If you have any issues or technical questions at any point, please feel free to message me. Now I'd like to introduce our first presenter, Dr. Rita Crane. Dr. Crane is with Rolling Oaks Radiology RadNet in Thousand Oaks. She is a board-certified radiologist with specialty fellowship training in breast imaging from Keck Medical Center at USC in Los Angeles, where she also earned her medical degree. Dr. Crane has participated in an array of research publications and presentations, and she's also fluent in Russian. I'd like to welcome Dr. Crane.
Hi, everybody. Thank you, Stephanie, for that introduction. So I am here to talk to you guys about a very important topic for all women and those who love them, and that is how to screen for breast cancer. And specifically, what is the state of the screening, breast cancer screening today, and what are the exciting things on the horizon that we can look forward to? Okay, so the title is Breast Cancer Screening, Present and Future. So nobody's ever really excited to get a mammogram, right? It's something that we have to do, like eating our vegetables. So why is it that we make you guys do it? We don't screen for every disease, okay? So the way that we choose diseases to screen for, it has to meet certain criteria. One of these criteria is disease has to be fairly common, which unfortunately breast cancer is. It's the most frequent cancer in American women. 1 in 8 women will develop some form of breast cancer in her lifetime. The disease is deadly or debilitating. Again, unfortunately, that's true. Breast cancer causes more death in women than any other cancer except for lung. There exists a cheap, easy, and fairly accurate test for the disease. And here we are lucky, we have the mammogram. And if we find the disease early, we can do something about it, okay? And so that is very true with breast cancer. In fact, since screening was introduced, there has been up to 40% reduction in death from breast cancer due to both early detection and improved treatment. So I'm going to skip the past and just go straight to the present. And so the exciting thing about the present is the 3D mammography. Okay, many of you have already had these or have heard about them. So what is and why is it different? So the 3D mammogram is different from a 2D in that the X-ray tube actually moves during the scan, okay? And so what it allows us to do is to have multiple low-dose images, okay, instead of one full-dose image. And it creates these slices of the breast that we can just scroll through, kind of like a CT, okay? The radiation is actually similar to a 2D mammogram. Your experience as a patient is very similar to a regular mammogram. It has been FDA approved for 11 years now, and it is becoming, and has already really become the standard of care nationwide. Medicare has been covering it since about 2015, and now most insurances cover it as well, although there may be some copay. So here is kind of a graphic of that. You can see this is your poor compressed breast. This is the image detector where the picture is formed. This is the compression paddle. And this is the X-ray tube, and it just shows it moving in an arc as the picture is taken, excuse me. And it creates these slices through the breast, okay, just kind of like slices of bread that the radiologist could then scroll through. And what it allows us to do is it allows us to see these cancer is hiding behind dense tissue. Like here, for example, you can see this little irregular mass that would be pretty impossible to see in a conventional 2D mammogram. And here's another example. Okay, so here's a cancer. This is kind of a blow up of this. And this is the same mammogram that's just 2D, and you're comparing it to prior year, and there's absolutely no change. There's nothing suspicious, but yet on 3D, this guy comes out. Okay, here's yet another example. I want to talk briefly about breast density before we go on. So breasts are generally categorized, when you have a mammogram, they're categorized by your radiologist into 4 different categories of breast density. So the first 2 categories are considered the fatty breast, and the second 2 categories are considered the dense breast. And it just has to do about how much of the dense white tissue you have compared to the fat. And why that matters is that women who have dense breast tissue are at slightly increased risk for breast cancer, both because there's more breast tissue in which cancer can develop, and also because cancer can hide behind dense tissue, preventing early detection. So those women who do have dense breast tissue can benefit from additional forms of screening, and namely that would be a screening breast ultrasound. Okay, so this is something that's meant to supplement screening mammogram rather than replace it. Oops, sorry about that. And so there's 2 kinds of screening breast ultrasound. There's handheld versus automated. So handheld is your traditional ultrasound that many of you have had, where a technologist uses a wand to scan your breast. And the accuracy of this is generally very good, but it does depend on the skill of the sonographer. And then it does tend to have longer scan times. The automated breast ultrasound is what you see here, where a large paddle is placed over the breast by a technologist. This is a lot less dependent on the quality of the technologist, but is somewhat dependent on the radiologist being able to interpret it, because sometimes there's difficulty interpreting it. But both are pretty good as additional screening modalities, and it's best suited for women in the intermediate breast cancer risk category, namely dense breast tissue. The caveats: it should never be used as a substitute for annual screening mammography unless there's some reason why you can't get mammograms, because many forms of breast cancer simply won't show up on ultrasound. There is risk of false positives, meaning that we can find benign things that we're not sure what they are, and so it'll lead to you getting called back and it getting worked up and sometimes even biopsied. So you just have to kind of keep that in the back of your mind. And please don't let this give you a false sense of security. If you have a negative screening breast ultrasound, many women say, well, why do I need a mammogram? Ultrasound didn't find any masses. So please note that a mammogram looks at the entirety of the breast. Ultrasound is very much dependent on where the technologist shows it, and we certainly can miss things unless we're looking for something very specific. So you really do need to do the mammogram. Please note that it's not always fully covered by insurance. Briefly, I'll mention screening breast MRI. It is very sensitive for breast cancer, okay? So it does tend to pick up breast cancers earlier than mammogram and ultrasound. Why we don't use it on everybody, several reasons, namely a lot of benign things can light up as well. And this leads to a lot of workups and biopsies and follow-ups. And so we don't want to do this for every woman, but women who are truly high risk, whose lifetime risk is over 20%, where you can check with your doctor about assessing your lifetime breast cancer risk. And if you qualify, this is a good option in addition to your screening mammogram. There's no radiation. You do need to get an IV to get contrast, and the exam lasts about 20 to 30 minutes. Okay, so here's an example of a breast cancer, pretty extensive breast cancer. This is an MRI image actually here, and it shows all of this white stuff is breast cancer, and it's pretty difficult to detect on the patient's mammogram, which is shown here alongside, pretty invisible. Here's another case of pretty extensive breast cancer seen on MRI. All right, let's get to the future. So what's new in the horizon? Really, what we're going to talk about is artificial intelligence, and this is the new buzzing topic in breast imaging. So generally, AI in imaging uses computer algorithms to aid the radiologist in detection and classification of abnormalities. The concept is old; it was around since the 50s and 60s, and went through several somewhat failed iterations, but only recently has it really been showing promising results, and it's been leading to a rapid shift in paradigm in breast imaging. It is important to note this is not meant to replace your human radiologist. we still need somebody to sue, right? So we're going to be around, guys. But it does allow faster and more accurate reads by the radiologist, and it's akin to double reading, to having another radiologist look at your mammogram. So traditionally, when AI was first adopted in a widespread manner in breast imaging, it was adopted in the computer-aided detection paradigm. Or it's called CAD. This was the first wave of AI with widespread use. It is task specific, meaning you have to program it to perform every single detection task. And it was helpful to an extent, but it did have limited utility because it created a lot of false alarms that the radiologist then had to clear one by one. And so it actually increased our reading time instead of decreasing it, as was promised. And it did lead to a lot of false positive recalls, meaning we call patients back for things that weren't cancers, weren't necessarily that suspicious, that we may not have called them back for, but the AI would point it out. And so it was kind of frustrating for radiologists until deep learning came along. Okay, and this is really a game changer. It uses artificial neural networks to extract progressively higher level features from data. Okay, so it is essentially a self-learning model. It is task agnostic. Okay, so it can learn. It teaches how many different tasks. You don't have to program each feature. And it shows extremely promising early results. Detection of cancer is similar to a human radiologist, and it decreases reading time and false callbacks. So there was a recent study done of over 100,000 women, which found similar detection rates from this type of AI compared to breast-trained radiologists, which is really amazing. It reduced false recalls by up to 25%. It reduced radiologist workload and burnout, which is actually very important because there's a looming shortage of breast radiologists, but there's no looming shortage of breasts. So we still need accurate reads, and this is going to go a long way towards that. And this worked well across all types of breast densities. And here's an example of an AI versus CAD. Okay, so this is a CAD mammogram, and you could see there's this star that the arrow is pointing to. Well, this is representing a normal lymph node in the breast. Okay, and the self-learning CAD understands that, and therefore it didn't mark it and didn't mark any of these other things. It only marked this area, which was suspicious. So this is very helpful to us because a radiologist knows that these are all benign things, and now we just don't have to go through that and clear it. Okay, so at Rolling Oaks, we use deep learning AI from Deep Health. It's called SageDX. And this is really exciting. It shows improvement in cancer detection across all radiologists. And in early results, it shows potential for early detection of cancer by up to 1 to 2 years compared to radiologist read alone. I have been using this for several months myself, and I have already found it very helpful in detecting subtle cancers. And this has been FDA cleared, so we expect it to be in widespread use. AI does exist for other modalities, for MRI and for ultrasound. We actually have used the ultrasound AI in our office as well. And this just is meant really as a tool to help radiologists decide how suspicious is the lesion we're looking at. So that's the end, and that's the summary of all the exciting changes which are coming and of this rapid paradigm shift that is all meant to keep you healthy and keep you going. Thank you all so much for listening, and I look forward to answering all your questions.
Now I'd like to introduce Dr. Valentina Bonev from BreastLink Medical Group in Orange County. Dr. Bonev is a fellowship-trained breast surgical oncologist and high-risk breast cancer specialist. She earned her medical degree from the University of California, Irvine School of Medicine, and she received her fellowship training in breast surgical oncology at the Lynn Sage Comprehensive Breast Center at Northwestern University in Chicago. Dr. Bonev has authored multiple research publications and has been an active volunteer teacher. In addition to the many services Dr. Bonev provides at BreastLink, such as treatment of both malignant and benign breast diseases, she also provides assessment and management of patients with high-risk breast factors. I'd like to welcome Dr. Bonev now.
Good morning, everyone. Thank you so much for joining us. Thank you to RadNet for hosting this talk. I am pleased to join Dr. Crane and Dr. Paddock this morning. We are going to talk about the importance of breast exams and what to look for. So first, we're going to review some breast cancer facts. We're going to talk about when to start breast exams by your provider, how to perform self-breast exams at home, some common breast lumps, and what to do if you detect a breast lump. And then we're going to wrap up talking about concerning breast cancer exam findings that may correlate to breast cancer. So here are some 2022 breast cancer facts. 1 in 8 women will develop breast cancer. So the average risk of a woman is approximately 12.5%. This year, an estimated 287,850 women in the US will be diagnosed with invasive breast cancer. In addition, 51,400 women will be diagnosed with non-invasive, also known as in situ breast cancer, and 2,710 men in the United States will be diagnosed with invasive breast cancer in 2022. So for average risk women, we recommend starting breast exams at 25 years old and repeating them every 1 to 3 years. This is part of the physical exam, and it can be performed by a primary care provider, such as your family medicine doctor, your gynecologist, or a breast specialist like a breast surgeon like myself. For average risk women at 40 years old, we recommend an annual breast exam as well as an annual mammogram. So an adequate clinical breast exam has multiple components. So there's looking at the breast, there's feeling. The patient is going to be sitting up as well as laying down on the exam table. The breast is going to be examined from the collarbone or the clavicle all the way down to the bottom of the breast, and then from the mid-chest all the way to the armpit. And then lymph nodes are going to be felt in the armpit and then as well in the lower neck. All women should be familiar with their breasts. You should report any changes to your healthcare provider, and this may facilitate detection of a breast cancer between routine screenings. And like we always say, you know your breasts best. So let's talk about a breast self-exam. So we recommend that you perform a breast exam once a month. It's easy to just pick the same time each month, like the 1st of the month or the 15th of every month. So it's easier for you to remember. If you have regular periods, we recommend that you perform the exam a few days after the first day of your period, because that's when swelling and tenderness is low. Some patients like to perform it in the shower. Sometimes patients perform it before bedtime when they're changing. It doesn't really matter, it's just whatever is convenient or comfortable for you. So mark it on your calendar or set a reminder on your phone. Look in the mirror, see if there's anything that looks obviously abnormal or different between the two breasts. Then you want to use the pads of your fingers, not the tips of your fingers, in order to perform the exam. And you're trying to feel for any lumps, nodules. You're also looking at the skin. Is there any redness? Is there any dimpling? And then you may notice, is there any nipple discharge on your exam or maybe even on your bra? You can also perform the exam laying down after you look in the mirror. And there's a couple of patterns that you can do, and you just pick what pattern is easier for you. This up and down pattern is known as the ladder pattern. I tend to do this when I'm examining my patients. There's also the circular pattern. And then there's the pattern starting from the edge of the breast and working your way towards the nipple. So whatever way is easier for you, but again, you want to use the, not the tips of your fingers, but the pads of your fingers so you can really feel for any lumps or bumps or skin changes. So when you do the exam, you want to notice, is there any pain even before the exam or during the exam? Do you see any nipple discharge? If you see discharge, what does it look like? Have you noticed it before? How often do you have it? Is it one or both nipples? You want to look for any skin thickening, lumps or bumps, skin dimpling or puckering. Pay attention to the nipple. Is it pulling in? Does one of your breasts look like they're swollen? Do you see any redness, or is your nipple itchy, or is there a rash? And this is another little card about the self breast exam and making sure that you're examining the entire breast from the top here, the lower neck, all the way to the armpit. Again, using the pads of your fingers, breastbone down to the lower breast. Now, some common breast lumps. First, very commonly is a fibrocystic breast, which is right here, known as lumpy, bumpy breast. So you have multiple cysts. You can also have a solitary cyst, and that can stand out as just one lump that you feel. And if you don't know what a cyst is, it's basically a water balloon or just a fluid-filled sac in your breast. Those tend to be soft and squishy. However, if they keep expanding and filling with fluid, they can feel hard, and it may feel like a breast cancer because they can feel as hard as a rock. But it's basically because the sac has expanded so much that it's now tense. Just like if you were to fill up a water balloon and you put a ton of water in it, it feels very tense. A fibroadenoma is a common breast lump. Now that's going to feel firmer, but that tends to be mobile, and those are common in young females. And then, of course, breast cancer. Most breast lumps are actually not cancer, and at least 80% of breast lumps that are biopsied are not cancer. So don't be alarmed if you feel a breast lump. Does not mean you have cancer, but it needs to be further evaluated. And for that, we recommend that you notify your healthcare provider right away if you detect a lump. Your doctor will then decide what to do for your next step. So they're going to first do a breast exam. And then depending on the exam, depending on the history you give them about the lump or any other concerning breast findings, they're going to order a mammogram. They may order a breast ultrasound. They may even order a biopsy. And then depending on these results, they also may order an MRI. So some concerning breast cancer findings. So like we talked about, a lump could be breast cancer, but it can also be a non-cancerous lump. You may have pain in your breast or even your nipple. There could be changes in the skin. You may feel some lumps not only in the breast, but in the armpit as well. That could be a lymph node with cancer, or that could be a lymph node because you had a recent infection. Breast swelling, redness or a rash, dimpling or pulling in of the breast, also pulling in of the nipple, which is known as nipple retraction or inversion, and then nipple discharge could be a concerning finding for cancer, but needs to be further evaluated. So to recap, we recommend that you perform monthly self-breast exams. We recommend that you routinely see your healthcare provider to perform a clinical breast exam. And then we recommend routine mammograms, and then depending on your age and family history, when you should start. But for average risk women, we recommend starting mammograms at 40 years old. So remember, early detection saves lives, and thank you so much for allowing me to speak on this.
Thank you, Dr. Bonav. Our final presenter is Dr. Bhavana Pathak, who is a general oncologist at the Memorial Cancer Institute at BreastLink in Orange County, California. She has fellowship training in oncology and hematology from the University of California, Irvine Medical Center in Orange. Dr. Patak has authored multiple research publications and has presented her work at many prestigious national conferences, with much of her studies focusing on wellness and resilience. Dr. Patak.
Good morning. Thank you, Stephanie. My name is Dr. Bhavna Patak, and I'm here to talk to you about lifestyle factors for optimal breast health. Today, I'd like to go over a couple things: what breasts mean to us, the incidence of breast cancer, what is breast cancer, the term survivorship, and then I'd like to go into detail about some of the risk factors or spectrum of risk factors that can be associated with breast cancer, and stratify them by evidence level. And then finally, talk about a topic called integrative oncology, or how we can use complementary alternative techniques to improve our health. So first, in terms of what do breasts mean to us, I think as women, we definitely feel that breasts are an intrinsic part of our femininity, as depicted in our society, in culture, and arts. In this artwork here, a sculpture, bronze sculpture called La Bella Donna by Sherry McEwen, who's a local artist here, depicts the experience of her aunt who had intellectual disability, intellectual delay, and was diagnosed with breast cancer in her 80s. And when Sherry, the artist, had asked her aunt, what does it feel like to have breast cancer, the one thing she was able to express is that she missed it. She missed her breast. And so, as you can see here, there was a square rectangular replacement of her aunt's breast to depict what it feels like. Additionally, breasts are often associated with the feeling of maternity. And so breastfeeding for women that have breastfed, or experience of being a mother, it's very emblematic of this. And so for these reasons, having a cancer of the breast can be very poignant, very challenging, both emotionally, physically, and sometimes even spiritually. In terms of breast cancer incidence, many of you have heard of this statistic, but it is very common, and 1 in 8 women are expected to develop breast cancer in her lifetime. And so it's basically very prevalent, but the good news is that it is very curable. So what is breast cancer? Breast cancer is a collection of cells that are growing abnormally or without control. And in this process, they turn into what's called tumors. Tumors can be either benign or malignant, or what we call cancerous. In terms of hereditary predisposition, only about 5 to 10% of breast cancer cases are caused by a hereditary cause. And I think sometimes patients ask me, is it genetic? Well, technically, all cancer is started at the gene level, but the type of genes that are often involved are the genetic information in your day-to-day normal cells that are not involved in reproduction or passed on. And so most breast cancers, 90 to 95%, are spontaneous. And so, and these are caused by defects in the DNA, the genetic information that lead to this abnormal cellular growth. Now, in this slide, although it's busy, I talk about how there are various risk factors in breast cancer, both the development of breast cancer and prevention. And so from left to right, they move in terms of factors that are the least controllable to the factors that are the most controllable. So starting at the left, things that are associated with breast cancer risk include, of course, being a female. The incidence is much higher in females. Additionally, the incidence of breast cancer increases as you get older, so after the age of 40. Having no children can increase the risk of breast cancer, as also having children very early or very late. Genetic factors, as I mentioned before, 5 to 10% of cases are hereditary. Having early menses, having menses before the age of 12, or giving birth at an older age after the age of 35. Not breastfeeding after giving birth can put a woman at higher risk for developing breast cancer. Having any type of cancer or family history of cancer can increase your risk for breast cancer. Having late menopause or having menopause after the age of 55. Using hormonal replacement therapy to treat menopausal symptoms can be associated with an elevated breast cancer risk. And as we're moving on towards the right, some of these factors you're seeing are things that are more controllable. So using hormonal birth control methods, eating lots of processed and fatty foods, exposure to radiation, and obesity, particularly after menopause, can be risk factors for breast cancer development. Now, in terms of survivorship, what is this term? Well, survivorship is the experience you have after having gone through breast cancer treatment. And so for many patients, this is a very particularly sensitive time. Will the cancer come back? Will I be able to pay the bills? What will my relationship or marriage be like? And I think it's important to know that this is a team effort. So everybody here at BreastLink, or all of your medical providers, are here to help make sure this is a smooth process. So now, in terms of breast cancer risks stratified by evidence level, things that we've already talked about: increasing age, female gender, body fat. But other things include things like dense breasts, hormone exposure to androgens, long periods of menarche, genetic mutations, personal history of breast cancer, also things like alcohol, smoking, night shift work, and things that are established to be protective against breast cancer include breastfeeding and physical activity. Things that are inconclusive, meaning there are some evidence supporting its association with breast cancer or preventing breast cancer, include things like soy or Mediterranean diet, red meat. The World Health Organization has categorized it as a class 1 carcinogen, and so I think that is becoming more definitive. Say a plant-forward diet is something that is having more evidence can be protective against cancers in general. And other things such as bisphosphonates as well, increasing evidence that this can be protective against breast cancer, particularly in women who have gone through menopause. In terms of negative studies, things that are are not associated with breast cancer include things like hair dyes, breast implants, abortions, things like this. We do not believe to be associated with breast cancer. And finally, I just want to touch upon a topic called integrative oncology, which is probably of some interest to women. We know that the majority of patients with cancer, or before or after cancer, like to engage in complementary and alternative treatments. That is, treatments that are in conjunction with standard Western medical practices, but that tend to be more holistic, patient-centered, evidence-informed, mind-body practices, lifestyle modification, natural products. And the goal is to improve your health, your quality of life, clinical outcomes, and to empower you to prevent cancer, or be an active participant in your treatment before, during, or after. Now, just a few things of note. One is that there is a lack of evidence for dietary supplements and botanical agents. So people trying to look for the miracle cure or pill, that is not found to have as much evidence as other modalities such as meditation, yoga, music therapy. You say the letters A and B attached to these things as some of the gradings or the level of recommendation. So meditation is actually strongly recommended to manage some of the symptoms that one can develop around breast cancer treatment, and to extrapolate that potentially even just lifelong in terms of prevention of these symptoms. So finally, to simplify, the lifestyle factors that can be helpful in preventing breast cancer, this includes avoiding alcohol, eating a healthy, probably plant-forward diet, engaging in exercise, and certainly engaging with your healthcare provider for obtaining routine screening. So to summarize, breast cancer is common and treatable. Survivorship is the process of living and thriving after having a breast cancer diagnosis, and is a comprehensive approach. There are a spectrum of risk factors for breast cancer, including things that we can control. And in terms of reducing your risk, weight maintenance, alcohol reduction, and exercise are evidence-based. And in terms of integrated practices for symptom management, this can include meditation, yoga, music therapy, stress management, and acupuncture. So thank you for your time, and I'd be happy to answer any questions.
Thank you so much, Doctors Crane, Bonev, and Patak. So we do have some questions, and I'm going to start reading them now to the appropriate doctors. And Dr. Bonev, if you want to share your screen, we'll get to some questions. So the first question I have is for Dr. Crane.
Okay.
And the question is the AI mammogram covered by insurance?
Okay, so that's a great question. Yes, the AI is included in the regular billing for your mammogram, which screening mammograms are almost always covered by insurance. The note here is that the new AI and actually much of CAD is assigned to 3D mammograms. And so if you're getting a 2D mammogram, you may not have the option to get AI with that. So that's a great question to ask because not every mammogram facility has AI or even has CAD. So that's not something that women think to ask when they're booking their mammogram frequently, but that is one question to ask your facility is do you offer CAD or do you offer the new generation AI? Because really it can make a difference for you in terms of, detecting those subtle cancers earlier. But yes, the answer is it should be covered by insurance. There shouldn't be any extra cost for that.
Right. And I guess also to check that a 3D mammogram is covered.
Right. So 3D mammograms, like I said, the vast majority of them are covered, especially by PPO insurances. The capitated or the HMO insurances, you really have to check individually. There are still a few that refuse to cover it, or you may have an extra copay. And those are all questions that you can ask your mammogram facility when you're scheduling your mammogram.
Okay, great. Thank you. Next question I have is for Dr. Bonev. And this question is, if a surgery is required for breast cancer, how critical is it to have the surgery done by an oncology breast surgeon versus a general oncology surgeon or even general surgeon?
That's an interesting question. So it's really, I'll go through the different type of surgeon. So it's based on their training and experience. So a general surgeon went through general surgery training, which is everything from breast to vascular surgery, transplant, etc. So this is someone who's in the community or one of the academic centers who operates on all these different types of patients. They could be doing bariatric, colon surgery, and breast surgery. These surgeons often only do literally just a handful of surgeries a year that are just on breast. So that's something to think about if you are a breast cancer patient or have any sort of breast issues when you see a general surgeon. A surgical oncologist, they did a general surgery training, then they chose to do a fellowship on surgical oncology. So this is going to be someone who did focus training on breast cancer surgery. However, they also did focus training on colorectal surgery, melanoma surgery. So yes, they are doing more breast surgeries than a typical general surgeon out there, but their focus is not just breast. Now, in my case, I did a general surgery residency training, and then I did a breast surgery fellowship. So my fellowship was on both benign and malignant or breast cancer disease. So I only see breast patients. So all day, every day, I just do breast. I'm in clinic or I am operating. I have seen and treated thousands of patients in terms of the clinic or in the operating room. And so it's good to ask these questions from your surgeon, because they may say, I'm a breast surgeon, but they're actually a general surgeon who does 3 breast surgeries a year. So it's something to consider, but ultimately the choice is up to you.
Okay, thank you for that. The next question I have, I think it's, either of you could answer this, so you can arm wrestle for it. The question is, with breast implants, is it more difficult diagnosing abnormalities? And what type of mammogram would you recommend for someone with breast implants and also dense breasts?
Okay, well, since there's a question of mammo, I'll start there.
Yeah.
So we do mammograms on breasts with implants every single day. This is not an issue in terms of getting you screened. You should absolutely have screenings, even if you have breast implants. You're still at the same risk as any woman without breast implants. So you're really at a disadvantage if you're not getting annual screening mammograms just because you have breast implants. The caveat is that so the way that we do mammograms on women with implants is we do a very light pressure mammo on the whole breast with the implant included. And that's really just to see the integrity of the implant itself, to look at the armpit, but we don't put the full pressure of the mammogram on the implant because we don't want to cause any damage to it. So then what we do is we push the implant back, and then we take another image of just the breast tissue that's in front of that implant. And so there's always a portion of the breast that doesn't make it into that image because the implant is in place. So it does limit screening somewhat, just because we can't see the whole breast. Breast exams become extra important in women with implants to make sure that we're, not missing those outlying cancers. And then those women, especially if you have dense breast tissue, you may benefit from adding screening breast ultrasound, which again will help cover some of those spots that may be missed by screening mammography alone.
Okay, following up on that, Dr. Bonev, if someone has had a double mastectomy and has implants, do they still need a breast exam, like a physical breast exam?
Yes, they will still need a breast exam. So once you've had a mastectomy or bilateral mastectomy, you're no longer going to get mammograms on that breast. And so your method of screening is going to be a breast exam performed by your healthcare provider.
Okay, thank you. Okay, so this question is for Dr. Patak, and unfortunately she did have to step out. We can definitely send this question to her, but I think one of you might be able to answer this question. In patient care, who is the driver, the PCP or the medical oncologist?
So it kind of depends on the institution where you're being treated at, but it could be the medical oncologist or even the breast surgeon. So if I have a patient with an early stage breast cancer who's primarily going to be treated with surgery and radiation and no chemotherapy, I see myself as the driver. I'm the one who's ordering all the imaging, the workup, the referrals. I'm constantly communicating with the patient. The primary care doctor is definitely involved because the patient obviously has other medical comorbidities that need to be managed, but the primary care doctor takes a little bit of a backseat because they're not cancer focused. But I think if a patient, let's say, is a stage 4 and they're being managed with chemotherapy, I think the medical oncologist is really going to be in that primary role. But it's also good to emphasize that the patient needs to be involved in their care too.
Yeah, for sure. Thank you. Dr. Crane, do you advise risk assessment post-screening for patients with dense breasts?
Okay, so risk assessment is basically what it entails is essentially it's a questionnaire, a detailed questionnaire that asks about your personal health history and your family history, and it spits out a number at you, and this number is kind of approximating your lifetime risk of developing breast cancer. There are several different models that physicians can use. So the taking of the risk assessment questionnaire does not necessarily need to be tied to the timing of your mammogram. nor is it necessarily dependent as much on your breast tissue density. Rather, it gives you an approximation of, based on all your factors, do you need any additional forms of breast cancer screening, such as ultrasound or MRI, or even some genetic counseling if your risk is really high. So it doesn't necessarily need to be timed to your screening mammogram, but it's a good idea for women to discuss this with the doctor to see if there's additional forms of screening that you may need.
Thank you. This question is, as a cancer survivor of triple negative breast cancer, 15 years out from first diagnosis, is it true that Gadavist, gadolinium contrast agent used in MRIs can affect memory long term? If so, what is the risk if you have had over about 15 to 20 MRIs?
Well, that is actually a very interesting question, because it's something that the scientific community is still working on answering definitively. It was, I believe, in about 2014 that there was a study that came out that showed that gadolinium does deposit in very tiny doses, leaves deposits in the brain of gadolinium. However, it has not been shown really in any studies since then to have any kind of negative effect, right? So what does it mean? Just because we detect the deposition of something doesn't necessarily mean that it's going to have a negative effect. So certainly nothing that we have seen that would be conclusive in terms of saying that this is a safety issue. And I do get this question all the time with breast cancer patients who do undergo screening breast MRIs, annual screening breast MRIs, because they have to be with contrast, otherwise it's not really useful. And so this is really a risk versus benefit analysis, right? And it's very difficult to analyze that when we don't have, and it's really kind of a new field in terms of what gadolinium does. But so far, the indication is that if you are at high risk for developing breast cancer and you require an MRI to survey that, to make sure it doesn't come back, the risk of you developing breast cancer that will go undetected is much higher than whatever effect the gadolinium will have. So generally, we say it's not a contraindication, and we just say, get the MRI that you need. But some women, this is something to discuss with your doctor. Some women say, look, maybe I'll get an MRI every other year, or stagger it with screening mammograms and ultrasounds in a way to kind of limit that. And so that's just a personal choice that you should discuss with your doctor for your care.
Thank you. Also, insurance doesn't always cover MRI every year.
Yes, that's a whole other thing.
Yeah. Yeah. Okay. Dr. Crane, this is
okay.
One for you. I am a 39-year-old. I have a cyst in my right breast. It was detected after having tonsillitis 3 years ago and eventually disappeared. Now I am having a lot of stress and recently discovered reappearance at the start of this year. I had 2 mammograms. Is it normal to have these cysts appear and reappear after some time? Also, is abortion a cause of breast cancer? Which I think that you covered. Go on.
Yeah, I think that the abortion question was answered as a no, it's not. So in terms of breast cyst, so I don't know exactly the specifics of this case in terms of how it reappeared. Was this something that was seen on imaging, or is this something like a lump that you're feeling? But generally, to answer your question, cysts can fluctuate in size. They can come and go. That is actually very common. If it truly was a cyst and an ultrasound, the cysts are usually diagnosed by ultrasound. They may be seen on mammogram, but the way that we tell it's a cyst is an ultrasound. And there's cysts that are very simple. They're just filled with simple fluid, and it's pretty much a slam dunk that that's what it is. Some cysts are a little bit harder to diagnose. They may have some debris floating in them, and sometimes we're not sure if it's a cyst. So generally, things that go away and come back or shrink and get bigger and shrink again, those things are benign. Cancer just goes in one direction. It doesn't shrink and come back. So if that's the symptomatology, if it's exactly in the same spot and still looking like a cyst, that is not concerning. Cysts don't turn into breast cancer. They're very common, benign. However, if you do have a growing or recurrent lump and you're simply not sure, the best way is to contact your doctor so that they could send you in for a diagnostic workup and your doctor can assess that.
Okay. Another question regarding breast density. Are there ways to measure breast density objectively?
So yes, there are software tools that some radiology practices use that kind of spits out an automatic, computer breast density. But, studies have shown that that's not 100% accurate. And when you compare it to the radiologist's classifications, it actually doesn't do quite as well. So we have not adopted that in our practice because of that, but I've worked with that software in the past. I just didn't find it to be a particular advantage, because the important thing is, really it's kind of an eyeball estimation, but the important thing is there more breast tissue than fat in the breast? And if it kind of meets that threshold, then you would qualify as having, a denser breast.
Right. And there's no way you can look at your own breasts and determine.
No, there's no way you can look at your own.
Right.
No, don't read the internet. There's no way to do that.
Right,
no.
right. Okay. Another question is, I'm a breast cancer survivor, triple negative. I have osteoporosis due to chemotherapy. Is it true that it has been scientifically proven that taking calcium supplements, vitamin D, has been deemed not necessary?
So if you have osteoporosis, whether it's from chemotherapy or due to aging, your doctor is going to put you on basically medications or calcium supplements to help with your bone growth. So you're probably not seeing your medical oncologist if you're 15 years out, but I would definitely see your primary care doctor on that and have that discussion, and also to see on your bone density study how severe your osteoporosis is, and to discuss starting you on medication.
Okay. Here's another, is this true or false? We've seen a lot about a connection between breast cancer and skin cancer. Is that accurate? Like things that say if you've had skin cancer, you are at higher risk for breast cancer, and vice versa.
And this is skin cancer, any place in the body?
I think so. Melanoma.
Yeah, there isn't a strong link for that, no. But if you have, let's say, a family history where multiple family members have multiple cancers, and you had a cancer, let's say a skin cancer, there could be a genetic component, a gene mutation associated.
Yeah.
So,
yeah. But like a direct link between the two is not actually
right.
a thing. Right. Okay. Okay. Do you have any other questions before we wrap it up? Jesse? Anyone else? Okay. Okay, well, then we're going to wrap it up. And if you think of another question at some point that you want to ask, you can email concierge@breastlink.com. And also, this full recording will be available on our website at breastlink.com, and also on our YouTube channel and on social media. And please follow us for this recording, future webinars, and other breast health information. And I want to thank all of our presenters so much for this really interesting presentation. And thank you to BreastLink for hosting. And again, if you want more information, please visit www.breastlink.com. And thank you all for joining us today. Thank you so much.
Thank you.